Professor Bettina Hansen. She's a senior biostatistician and associate professor at the Toronto Centre for Liver Disease and Toronto General Hospital at the University of Toronto. She's the leader of a global PBC study group, which is very productive and has been published so many papers with excellent results. So, Bettina, please.
Thank you. Good afternoon, Chairman. Good afternoon, ladies and gentlemen. And thank you, Professor Tanaka, from my heart that you invited me here to Tokyo. It's an exciting city, a beautiful, beautiful place. So this is my first time in Japan, and I'm truly excited. These are my disclosures. And I have a second slide of disclosures, or maybe more a warning. I'm not a hepatologist, I'm not an immunologist, a geneticist, but a biostatistician. So I'm going to take it from a different viewpoint that you've seen today and yesterday. Originally, I'm Danish, moved to the Netherlands when I was 25, and since recent, I live in Canada, in Toronto, where it's very cold. We have studied the last few days the rare diseases or rare and distant outcomes. When you do that within isolated single-center studies, you have few cases and few events, which is one of the problems with, for example, PBC. Results are heterogeneous across these centers, mainly because of the background population is different or the way that people are treating their patients. If you look at primary biliary cholangitis, it's a rare disease by definition, slowly progressive, it's chronic, and most patients nowadays present with mild disease. That's what we have the plot here on the right side. You see the red balls are presenting the mild biochemical disease stage, and that has increased over the years, while the severe stages are still going down. First-line treatment, as I was just presented, as UDCA still. And for those patients who do not respond well to UDCA, there is the option of fibrates or FXRs nowadays. However, when you want to study new compounds like the fibrates or the FXRs, and you want to do that in a real clinical trial, and you want to study the true endpoints, like the regulatory, they really want to see you study this in the true endpoints, like liver transplantation or death, you have a problem, because not only is disease rare, but there's also, it takes a long time to get the event. So we also have rare events or long distance events. So a trial duration will take more than 8 years, probably even 15 years. That is unethical for the patient. You cannot ask a patient to participate in a placebo-controlled study here that takes 8 to 15 years. When you have the option of maybe something that really works. So there's a hunt for a surrogate endpoint, an early response, hopefully not invasive and cheap, to capture the true endpoint. Already in 2006, Albert Parés presented the biochemical response criteria of ALP decrease of more than 40% from baseline, or normalization after 1 year of UDCA. Paris 1 from Copichot came 2 years later, and we in Rotterdam at that time presented the more disease stage with albumin and bilirubin. Toronto had the criteria of lower than 1.67, which is very much adapted nowadays. And we have also the Paris 2 criteria in 2011. These are not all the criteria, but these are just to show you, if you look at the red numbers, that these were actually single-center studies and would have very few events, actually. And they are very different. All involves ALP, that is, but very different in the way that they capture response. So when you look at the observed response percentages within the global PBC study group database, it looks like this. Very different results across the criteria. And if you actually have patients that fulfill all the 5 criteria, there are only 25% of them. So what I'm trying to say, single centers studies are nice and it gives a good idea, and this was the best at that moment in time. But now you need to collaborate. You need to exchange expertise, and you need to get a better understanding of the disease. There's a need for this. We need to share and exchange expertise and new techniques. And not only in collaborations, but also in a network. It's more than a registry. You are able to share data, so that is the registry, but you can also share the expertise and techniques within such a network. And the nice thing is you can validate earlier findings. So we can validate these old rules of response criteria. I call them old already. We can describe better the natural history, especially within different subgroups, like the male population, for example. We can study better, are they really truly different than women, or are they simply just diagnosed too late because it's not recognized? We can monitor safety and harm and quality of care, maybe even quality of life, if we put it up a prospective way. With this idea of a network, you can gain new knowledge, we can ask more questions, and we can therefore update the guidelines. It is also an important source for setting up a trial. So a lot of the times, not only from one company, but a lot of companies come and ask, how do we design a good study? How do we use the data, the knowledge from the natural history that you have now to make the best design of a study? What is the power analysis? How long time do we need to follow them? What subgroups should we look at? What are the inclusion-exclusion criteria? You want to capture the total spectrum of disease in the recruitment and to show that any new drug actually works. So this is important for the trial design, for inclusion-exclusion criteria. But more important, as I just mentioned, one of the things that is difficult, regulatory asks to do those long-term studies, because it's always been the case. We need to do a study with endpoint of liver death or liver transplantations. But as I said, most of these patients do not want to get involved in such studies because it takes too long time. So one of the things that we are working on right now is actually to use these databases as historical controls. It's not only within PBC, but it's also especially within rare diseases for children, where you need to have some kind of control and to match it in a very fancy statistical way. So that's something new that is coming up right now to hopefully speed up the process of getting new drugs to the patients earlier, still in a safe and controlled way. So as you all know, probably the Global PBC Study Group is an international network, and at the moment it represents 23 liver centers in 15 countries. It's actually a retrospective study, which makes it a little more easy than the prospective ones that are running right now. But it's the best we could do at that moment to get quick data together. It is actually what you would call a meta-analysis of individual patient data from major long-term follow-up studies. So we asked Pares, Corpuscio, please join together the data together with Keith Linder, and we have already a big database. So within a very short time, we were able to get to 6,000 PBC patients. Not only do we have the time of the diagnose and the characteristics of diagnosis, but we have actually captured all patient visits in that cohort. So that includes more than 49,000 patient visits with all biochemistry variables. And there's a 20-year follow-up because of the retrospective art of the study. We are now in 2019 and 20. We are planning to make a new update and include new centers and hopefully more Asian centers as well, to have the possibility to look for differences in where the geoepidemiology. So from a rare disease, we have made a gigantic database. But a global PBC study group is not only one database, it actually includes several databases now. So we have the OCA database of how we treat patients outside the trial. Professor Tanaka has, together with Christophe Cobochot, now also started making a database on fibrates. We have a database on liver transplantation and one on young PBC patients where we match them with all to see whether they're more aggressive kind of PBC. So when you look at the journey of what we did until today, we started in 2011, 2012, and we are now in 2019 with 9 published papers, 3 in review and 19 papers in preparation. One of the things that has been mentioned several times these 2 days is the GLOBE score, which we created, and at the same time you had the UK PBC score, and there are sort of new kinds of idea how to predict survival and liver transplantation. We also actually have an app, if you're interested, very easy to download and very easy to use, so that makes, I think a lot of people actually use it in the States even. What it does, if you calculate the GLOBE score and you look at the quartiles of the GLOBE score, it very easily demonstrates that there is a Verity of Survival here. When you look at the lower quartiles, you identify quickly the one which will have liver transplantation or death. So it performs reasonably well. I think you can always do better. The GLOBE score is made of biochemistry variables, and there's no FibroScan in there. So one of the things that I could imagine happening in the future is to include FibroScan variables in there as well. But what is nice about the GLOBE score, it actually compares to a matched population. And now again, I must excuse myself, because this is a matched population from a Caucasian population background. So I think it's important to do that in a new way, looking also at different kind of populations. But what we did do is actually to match it with the life expectation from a matched population. And when you have a GLOBE score, which is less than the 15th percentile here, you have a similar survival to the matched population. While is it above this threshold of the 50th percentile, you have immediately a sort of group of patients which you can find that have a worse prognosis. We actually also did that in a very stringent way, looking at different thresholds. And I just want to show you something that we are also expecting to publish, hopefully. It's already presented at APASL in 2017, so that's a long time ago, but we still have to do some fine-tuning. We have a patient A here, for example, here, and a patient B. One is 67 years of age and start of UDCA. Normal albumin and bilirubin at start and at 12 months. And if you then calculate the GLOBE score over time for each visit that the patient comes into the clinic, you see at a certain moment at 7 years, there is already a sort of explosion of the GLOBE score, and it starts to increase. And this patient actually had a liver-related event at 11.5 years. The other patient here stays under this threshold, age-specific threshold that we made, and was alive at 16 years in the last follow-up. So what is the idea behind this is that you can actually use the GLOBE score in a dynamic way for each visit that the patient comes in. You can calculate the GLOBE score and see whether it passes this age-specific threshold, and in case it does, there should somehow ring a bell saying maybe we should look at other treatment options. So the biochemical response criteria has been updated, as was just shown, that we have the UK PBC risk score as well, which is also a very good risk score and performs in similar good way like the GLOBE score. So what is PBC today and tomorrow? How do we manage the PBC? We need to better still understand the PBC natural history and all the subgroups that we have there. We should target treatment in a better ways. Now that we have more options, we should find the ones that do not react to UDCA in a better way and identify those patients with unmet need with appropriate risk stratification. We need to prove the benefit, of course, and we have to make sure that these new compounds are manageable and tolerable. And now I'm not even talking about economy. It's sort of fashion to have a PBC network. It's not only in PBC, it's also PSC, in children's and rare diseases. But even within hepatitis B, we have the Forum for Hepatitis B, where we look at different endpoints like S loss. Is it really linked to HCC, etc.? But within PBC, you see there are so many networks going on right now. It's getting really crowded, which is great. I mean, the more studies, the better. European reference networks actually is more delicate. It actually only includes newly diagnosed PBC patients. So that's something different than what the other studies have done. So what are the lessons learned? I think it's important when you want to create a network, make sure you immediately start off with a good and solid steering committee who actually also steers. Make a standardized case record form, but keep it simple. You can also keep it too simple, and one of the experiences I had with the PSC study group in that big cohort that we have there, it was simply too simple. So you can't do very much more than we already did almost, because they only had diagnosed no treatment, no biochemical variables. So that was a little too simple. So you have to think clever how to capture things that you can then study for a longer time, because it's a lot of work setting it up. Nowadays, you need a lot more ethical approval and data sharing agreements than 6 years ago. And that's one of the things we have to do right now, is to go back and get all those new approvals with all the new regulations that are out there. So I think that's something that takes time and involvement, not only from the steering group, from each center. And that's just something we have to do. And each center is different, so we have to take it one step at a time. One thing I also think is important is to be flexible. Needed help, then go and get some help and make sure that it's settled. And if you make too many rules, you strangle the project. So try to keep it simple in that sense as well. On the other hand, you want to collect data and ensure quality, and that's time consuming, and you just need to take your time for that, but also have a sort of deadline. The data should be captured within half a year or a year, because otherwise it just takes too long time. Avoid bias is important, so we need to make sure that we have the right inclusion and exclusions, not only for entering into the network, but also with every study that we do. I think it's important to have a good network, that you stimulate young investigators, and that strengthens the group. I'm already the old one, and we need to have some new ones in the next 10 years to come up and stand here and give a talk. So I think it's important that you stimulate research input and questions from all participants, and everyone should be able to do that. And I think we're doing a good job in the Global PBC Study Group. A lot of the projects are not originally from Rotterdam, but actually from Birmingham, from Italy, from Toronto, and now from Japan as well. I think that's really fascinating to see. You need to keep the network sustainable, so you make sure that you have finance to do it. You have to have new projects and make investigator meetings, newsletters, TCs, a website. So keep short lines, and make sure that you have early output when you want to achieve success. What is the next level? Because of all these different networks happening everywhere, and it gets rather confusing actually. Michael Mans asked me also, what are we going to do with all these networks? Isn't that a little too much? And I think he's right. I mean, we have to watch it that the data is not entered twice in all kinds of different networks, because then it gets messy. But maybe we have to just join the forces together. And I think it's important also now to include patient groups, regulatory agencies already from the beginning, pharmaceutics, and healthcare providers, because it's the new thing. We are going to have to work together, all of us. And I think that's one of the things that we are doing today at this meeting. We're discussing the patient's involvement and how to make sure that we give guidance with respect to regulatory agencies. I want to thank you all for listening, and a special thank to you, Professor Tanaka, here circled in one of our investigator meetings at ASLD. Thank you very much.
Yeah, thank you very much. Very nice speech, lectures. Yes.
You were biostatistician, so that's why I'd like to know the methodological question. Is it possible to perform comparative effectiveness research using kind of the international data, for example, to compare the superiority or non-inferiority between OCA and bezafibrate? What kind of that?
I think that's a very interesting question. Absolutely, I think that is possible. I think it's also important to mention that the Global PPC Study Group is totally independent of pharmaceutical industry, even though we do get finance from them, but it's unrestricted grants. So this opens the opportunity to actually compare OCA with fibrates. And when we have the data from OCA, we are collecting the data from fibrates. It opens the doors to compare these things, yeah.
Thank you.
So any other comments or questions? Okay. Okay, so thank you very much.
Thank you.
So now we go